Welcome back. This is session 2 of 5 on analytics practice for Lurie Children's operational leads and leaders. Today we're going to talk about how you develop a good intervention and how you develop good questions to ask in order to determine whether or not your intervention is doing what you want it to do. But first we're going to start by reviewing a couple of things really high level from what we talked about last time. Last time in session 1, we talked about there being 3 modes of inquiry in any learning health system. And those 3 are clinical translational research, quality improvement, and program evaluation. And they each play a very different role, but they often interweave in interesting and complicated ways. And managers and operational leads in healthcare settings like Lurie Children's have to be able to manage their way in and out of these different types of inquiry in order to use the best of them in every situation depending on what their needs are. All of these modes of inquiry have a lot of things in common. They're all set in real life world settings. A couple of them might use ideas around control and comparison that are used in more traditional research, but either way, the real test of them is the thing that they're trying to do, is the intervention they're trying to do working well in a real world setting with all of the chaos that can happen. All of them are focused on outcomes. All of them are focused on the complexity of implementing a new idea or a new treatment in a real world setting. They're all very much driven by being focused on processes, and they all really focus on disseminating the results from a more theoretical place to a much more real world place. So they have a great deal in common. They're not the same things, but they have a lot in common, and they are used very heavily in learning health systems. This chart just helps us think through how each of the different modes of inquiry has a role in the learning health system. Traditional research, as we discussed last time, would perhaps talk about how to use mold to cure strep throat. That's a very theoretical question, and it may or may not ever have application in the real world. We spend a lot of time in traditional research trying out ideas that may not have an application that you can think of right then, but that's the nature of traditional research. In translational research, the questions really reshape to say, okay, let's say we have something to treat strep throat. How do we do that in a clinical setting? What if we, for instance, had children who had strep throat take it every day for a week? Is that a sufficient treatment to cure strep throat in real children with the real disease in a real clinical setting? Program evaluation would take a kind of a different look at it. It would say, presuming that the treatment is effective, does this clinic do a good job of screening for strep throat? Do they provide penicillin in a timely fashion? And maybe do the families comply enough with treatment that they're able to get to cure strep throat as the medicine is supposed to? And quality improvement would ask a really different question, but obviously interrelated to these others. And that is, how do we increase the screening and treatment rates in this clinic, assuming that strep throat can be cured by penicillin, assuming that we are actually implementing this properly? How do we get it so that we're doing it more consistently across all clinic encounters that are relevant? The other thing that the 3 modes of inquiry have in common is that they really go through this learning cycle in a very similar way. This is something that's very familiar to in the learning health system. It's also very comfortable. It has a lot of crossover with the PDSA cycle, the Plan, Do, Study, Act cycle that's used by quality improvement folks. I like this one in particular because it calls out a couple things that I think in most healthcare settings really become a little problematic. That is, the 2 things that I think are particularly problematic are how the problem gets defined for the organization. And then once you've designed a solution, how that solution gets implemented. Any leader knows that once you have a solution on paper, that's a huge accomplishment, but getting that solution implemented in the real world can be pretty challenging. And lots of things come up that you didn't expect. So this diagram really pulls a successful implementation as its own milestone, which I think is important. For today, we're going to talk about designing the solution and the implementing the solution, kind of how those two things go together. We're going to focus on something called implementation, or I should say intervention theory, and we're going to talk about what makes a good question for evaluation, quality improvement, and research purposes. So before you design an intervention, as I just mentioned, it's important to spend a lot of time thinking about the problem and what the problem is, what the outcome is you're going for, and what resources you might have available to help you solve the problem. Sometimes people aren't aware of the resources around them, or sometimes they design programs that have resources that they could just never have available to them. So it's a good practical check to think about what resources you might actually have. But going back to the idea of defining the problem, lots of times when we go to the literature or hear about a successful intervention at another hospital, we want to take that intervention and plop it into our clinical setting. I suppose that there are times where that can happen, but most of the times the problems clinics have are very different from one another. And a solution that worked really well in one setting might not work well in this setting. So it takes there's a great benefit to sitting back and saying, let's be precise as we can about what the problem is we're trying to solve and what outcome we want. And then thinking of the intervention secondarily. You might actually end up changing the intervention, looking for a different intervention, or just reshaping the one that you are trying to adopt in a way that's unique for your organization. When people who want to study interventions and know whether an intervention worked sit down and talk to people who design interventions, one of the biggest challenges they have is understanding what the intervention is. And the intervention theory is a way to do that. It's a way to kind of open up what the intervention is and kind of surface all of the disagreements and confusion about it, because it is always confusing in every experience I've been in, and to get away from treating interventions like there's some kind of black box. We really want to understand all the pieces of the intervention that are going to go on, how they might interplay with each other, how one might be successful at the expense of another, how two might be successful if they're happening together. We need to really kind of talk through those things before we get to the implementation stage. Intervention theory is a good kind of tool to help you think through the intervention. So before talking about what intervention theory is properly, let's talk about what to think about when you start thinking about an intervention, what an intervention should look at. And this is really before you put anything on paper, when you're just in the kind of throwing a bunch of ideas at the wall, like what could we do to make this thing go better? So the first thing you really want to look at is the current knowledge base. And you want to ask the question, based on what we know from the research literature, from current patients, from what we've tried in the past, what might work? What could work in this? We've defined a problem. What could work? And what might we learn from other organizations around us or other clinics around us? We're maybe not the first one to try to slice this loaf of bread. Perhaps someone else has learned something along the way that we can really benefit from. You need to consider the time frame that you're going to have until you need results. Lots of interventions. It's pretty easy when you're designing an intervention to have the perfect be the enemy of the good, to design such a fantastic, beautiful, giant intervention that you're really not getting results in a timely fashion. So you need to really think that through. What's the real time frame we need to pay attention to, and how do we step this out so that we can get some results in a good period of time? You need to be thinking about who's making demands on the system, who's upset that the system is not working quite the way it should, who's wanting to see it improve, and what their experiences or expectations are around the improvement process. And then, of course, thinking about time, money, expertise, going back again to the resource question. Do we have enough resources? Do we have the right resources to be successful? And one of the things I always like to do is have people go through the process of dreaming big about what the perfect state is, not because that's what we can do right now, but it'll make sure that whatever we do right now fits really well with the long-term goals. You don't want to have a short-term solution that you end up undoing in order to get your long-term solution. You want all of your solutions to fit together in the end. So intervention theory is a set of beliefs that underlie action in an intervention setting. It's the reason you're doing this intervention, and it's all of the assumptions you make about why that intervention is going to work. It doesn't have to be scientifically proven at this point. It just needs to be reasonable to all the people who are participating in the intervention design. And the idea of the intervention theory is it connects if and then. In other words, it connects the outcomes you want to achieve with any actions you put into play. So if, for instance, I wanted to build a care coordination group that would reduce readmissions to the hospital for children with spina bifida. Let's just put that out there. I would take as my outcome readmissions for spina bifida, and then I would lay out whatever intervention I was doing through this care coordination group. And the exercise is really to kind of show that it's kind of logically connected, that the actions you're putting in place really could, if they worked right, really could have an effect on readmissions for children with spina bifida. So the idea here is that you're really kind of going through the exercise of saying, if I want X, how do I get there? And the intervention theory is a way to lay that out and get agreement on it. It's important at this stage in the game to know that whatever your intervention theory is based on, the beliefs do not have to be correct. It is better, of course, if they're based on science and real knowledge about what's going on in the clinic, but lots of times we don't have that. We just have to make some pretty good guesses about what cause and effects we're going to see in a real world setting. Importantly, in an intervention theory, the assumptions about what is driving action, what is driving outcomes, don't have to be agreed upon. One of the benefits of using intervention theory as a tool is that it surfaces a lot of disagreements among the stakeholders, a lot of unexpected confusion about what causes can create what effects. And because it does that, it's an excellent tool to kind of surface all that, and the group that's doing the planning can talk it out and sort through then an idea, an intervention theory that they can all agree on. Again, the intervention theory doesn't have to be true. It just has to pretty much explain how the outcomes could result from the inputs from whatever intervention you're putting into place. And as I said, the purpose of the exercise is to surface all the assumptions that an intervention rests on so that you can test those assumptions and ask the question are those assumptions worthwhile assumptions? Are they correct? I want to just pause and think through how intervention theory connects to some other concepts and ways of laying out action in a diagram that are used in other fields because they're interrelated, and operational leads and managers in healthcare settings will be dealing with these ones as well. The first one I want to talk about is key driver diagrams. Key driver diagrams, unlike intervention theory, which is generally looking forward, key driver diagrams are typically looking backwards. And they're not theoretical. It's not a question of what am I assuming contributes to an outcome. Key driver diagrams result from an effort to unearth what really does drive an outcome. So it's much more of a kind of a forensic, looking back, digging up what happened kind of an exercise. Intervention theory surfaces assumptions about cause and effect in a prospective kind of way. It doesn't claim that they're correct, just that people are making those assumptions and that we need to talk about them before we put our intervention into place. And a key driver diagram tends to look backward. It's not a negative thing. They're very, very useful to doing that. They're often the result of a root cause analysis where you're really trying to understand what's driving the organization to be making certain types of mistakes. So they're very, very useful, but it's different than the intervention theory, which is much more prospective, much more kind of designy, trying to put a design out there that people can agree to, and then once the design is in place, then figuring out how you're going to implement it. The other concept that intervention theory is closely related to is the notion of a theory of a change. And this really is a concept that focuses on what should contribute to an outcome as opposed to what does contribute to an outcome or what could contribute to an outcome in the case of intervention theory. Similar to the key driver diagram, theory of a change involves laying out what you know will make a change happen. These tend to be used for social, economic, or behavioral interventions much more than they're used for clinical treatment type of interventions, unless you're trying to, unless the intervention is trying to change behavior in your patients. They tend to be very prospective, and they're used probably less frequently in healthcare than the key driver diagram and intervention theory, but they are used, and there are times where you really want to have a good theory of change. A good example of where we want a strong theory of change is when we're trying to change the culture of an organization, or like I said, trying to change repeated behaviors that aren't necessarily linked to tasks or anything like that. We're trying to kind of change the judgment and the way an organization might exercise judgment in some complex situations. So I want to give you an example of an intervention theory and what the process of doing an intervention theory kind of as a group can do for you. One of the things, and the process also I want to mention that the importance of bringing in stakeholders that sometimes aren't always involved with developing improvement processes. This is a very simple intervention theory about building a new web-based registration process with the goal of improving patient satisfaction. And in our case, typically that means parent satisfaction since they're doing the one registering. So oftentimes when we build a system, we build it like this. This is our intervention theory. We know parents have asked for online registration. We want to then therefore build the registration, train the point of service staff to offer the registration to parent, give the parent access to the registration, and voila, the parent will be satisfied. This is really based on some big assumptions, though. And if you use intervention theory as kind of an intervention development tool, you can surface some of these assumptions and think about them more proactively. So, for instance, one thing you want to know for sure is, will the parent actually use the online registration? And will the parent's experience of registration, will it be faster and easier if it's online? Parents might ask for it. You might be able to build it, but maybe what we build is not in keeping with parents' expectations. So really kind of surfacing these additional assumptions help design an intervention that is more precise. There's additional assumptions that could be surfaced in a collaborative team meeting where you were kind of sorting through all this. For instance, that the point of service workflow includes the offer it includes the time to do an online training or orientation for parents. That the point of service staff are incentivized to offer the online option. If they're really backed up and they're incentivized just to get people registered and on, they might drop the online registration setup for parents on the way. And so fewer and fewer parents get set up for online registration. Parents need to have the capacity and have to really want to use the online registration system. Sometimes what we hear from parents is or from our clients, are the squeaky wheels are the ones who have strong feelings, and maybe they're ahead of the rest of the patient population, and maybe the rest of the population isn't quite ready for it yet. So we think it's solving a big problem, but maybe it's only solving a problem for a very small portion. So thinking that out ahead of time will really help you develop an intervention that will be most effective and most appreciated by families. And then there's additional things like the parent is the right target for the system. Maybe it's the adolescent, or maybe a guardian or a grandparent is the one who manages it. Maybe the online system is not very responsive. And so maybe many of the things parents call and get answers to when they register aren't included in the online registration. So is the experience as rich as the parents need it to be? Just some additional things to think about. So this is the process of going through developing intervention theory, helps everybody kind of put all of these questions on the table. Doesn't mean you have to test every single one, but it really kind of helps you understand where the potholes might be and be a little bit more proactive in designing an intervention that addresses some of these potential problems. So as I mentioned, intervention theories are great at surfacing disagreement about what is and what should be happening. They kind of force everyone to make a very logical connection between what you want to do and the outcomes. And I've had lots of experience where we put an original intervention theory on the wall. People looked at it and said, oh, that doesn't make any sense. Really, it doesn't make any sense. And so it's really good just to go through the exercise of developing one together. I think the other thing that's good about intervention theories, if they're facilitated well, they're completely value-free. Everybody just really lays out what they think, what assumptions they have, and they learn from each other and challenge each other, and hopefully over the course of a couple of sessions, they develop an intervention theory that everyone feels has some legs to walk with. Finally, the intervention theory really helps focus the planning group on specific questions that can be tested against the data during once the intervention is live. It really gets people focused on what are the analytic questions that need to be answered. The first thing you think when you put up an intervention theory with a lot of arms and legs and everybody surfaces all of these assumptions and connections, and it's a little frightening, and you think we're going to be collecting data forever. But really what it does is it really simplifies the data collection. It gets people focused on the outcome and on the key processes that need to be going right in order for the outcome to be reached. And of course, it's useful at building consensus about what the intervention would look like. And in fact, I think it's the key tool to be doing that. So here's an example of an intervention theory that we developed, a close colleague of mine and I, and a number of our team that worked on the flu vaccination program for our hospital. And this was our intervention theory. We thought the key problem we were trying to solve is that vaccine tends to come late in the season after flu is active, or potentially after flu is active. We usually get a limited supply, and so we would like as a best practice to make sure that children who are at most high risk for complications from the flu get the vaccine first. So our big innovation in our first year of doing this was to build a high-risk registry for patients who are at risk for complications from the flu using CDC guidelines, and building best practice alerts to let clinicians know once we have the flu vaccine which of their patients are at high risk, and so that the flu vaccine can get to those patients most quickly. And then the rest is a workflow that clinician offers the flu vaccine, the parent will consent, the clinician orders the flu vaccine, and the child is vaccinated. But in truth, this is pretty much how it went the first year. The children who were vaccinated first were children who were at high risk. Many more children were vaccinated, and the ones who were at high risk got vaccinated sooner. So we felt like that was a huge success. But as we went through the implementation in the first year, we surfaced a lot of things that if maybe we had taken some more time, we would have seen. So one of the things we didn't expect is that the clinician initially didn't agree. Clinicians had problems with the kids that were identified as high risk by our best practice alert. This problem was solved by providing some training and showing them the connection between the CDC guidelines and the clinical guidelines we put in place. So that was something we could address relatively quickly. One of the challenges we had that clinicians didn't all agree that it was their job to give the vaccine. This is because of the clinical workflow, because some clinicians are highly specialized clinicians and are not used to giving vaccines. Some clinics don't have nurses that would be administering the vaccines. So it was for a subset of our clinicians, it was kind of a little bit of cultural and workflow change to move them towards comfort with giving the vaccine and to support the clinics in a way that they could actually do it effectively. We assumed a clinician would have time to give the vaccine, and of course that was an error. We knew that there would be parents who would be resistant to the vaccine, and we did a lot of training in our first year with both parents and with clinicians on how to help them talk through the issue of the importance of the vaccine. And so I think we made some progress there, but not as much as we would have liked to. One of the things we didn't expect is that the vaccine was available in the pharmacy for this particular patient, that there are certain vaccines that are useful for certain subsets of patients and some that are preferred for others, and kind of working with the pharmacy to make sure that they had the right, that the way they ordered new vaccine was in sequence with how we were giving out the vaccine was a problem we really didn't expect to have. So again, if we had in a perfect world, we would have identified all of these things ahead of time and thought through it and had those things in place, but we didn't. We did the best we could. And I think in many respects, when we think about how we build interventions and desire to pilot them, this is one of the reasons we want to pilot. We want to surface all of these assumptions and problems that might happen during implementation, and be more proactive and more set up for success when we go large. So there are good intervention theories and there are not so good intervention theories. And what I mentioned earlier is that intervention theory is pretty value-free. We don't really, when somebody comes with an idea, we're not going to say it's a wrong idea. We're just going to say, let's talk about the idea and let's see if it seems to make logical sense. But there are ways to make your intervention theory better. I just mentioned one, and that is piloting, going out there and saying, I think this is the way it works, and I think this is what's going to happen, but let's try it out in a small group of people and see what additional problems surface that we didn't expect to see. But when you're building an intervention theory, there are some other tools you can have to make the intervention better. One is it based on generalizable knowledge? And I know that folks who work really deep in the weeds in the clinical quality improvement and process improvement will say that there's not much that in the generalizable knowledge world that is going to help them develop improvements for many of the programs they're working on. And I think that that's probably true. But I do think that there's a lot to learn from other organizations, and though it might not be generalizable in the way that we traditionally think of generalizable knowledge, I know that there's a lot of knowledge sharing between hospitals on even very, very small improvement, or I should say very narrow improvement efforts. And then the other really big topic to take on is local knowledge, and that is, how true is this knowledge in this particular location? And this is where quality improvement, process improvement folks really stand up to the fore. And a good intervention is based on a deep understanding of the clinical setting or the local setting wherever the intervention is taking place. It's based on a deep understanding of the problem and a deep understanding of the service population and the system that the program is being delivered under. it seems to me that besides piloting, that this local knowledge is especially helpful. Improving local knowledge is an especially strong role for front-end staff, patients, and families to play. There are lots and lots of times we go in thinking, I've got the solution to a problem, and we deliver it in a clinic setting, and a parent or a child looks at us and says, what are you doing? This isn't working for me. So they have the best understanding of what it's like for us to live in the world we create with our interventions. And so giving them an opportunity to give us that feedback is an incredibly enriching experience, and it really helps improve the quality of the interventions. In addition, local knowledge comes from really honest conversations among the different stakeholders involved with the intervention or who have a hand in it. Some of these can be really tough conversations. There can be ownership issues, there can be ideological differences. And that's one of the things the intervention theory process really helps surface. Doesn't mean it's easy to deal with all of those, but once you have them on the table and they're obvious to everybody, you can start tackling them one at a time. And like I said earlier, it's not important that the intervention theory there's complete consensus about it, but where there's disagreement, you want to have that really well defined and really concrete. That will help you as you start your implementation plan and as you start developing your analytic plan. So let's talk about where analytics fits. This was a lot about interventions and how to put them into place and how to develop good ones. I always like going into an analysis plan with a good intervention model because it makes me realize that all the stakeholders have thought really hard about what they're doing, what outcomes they want, and what processes they need to change. And that makes analytics so much easier and more straightforward. So I want to talk about 3 types of analytic questions, and they're quite close to the way we think about interventions. There are 3 types of questions we tend to focus on: the process, output, and outcome. Process is pretty straightforward. It's just what is the thing you're doing in order to get your outcome. The output and outcome are confusing to people. The output is the thing you're actually producing, like in the flu vaccine example I gave. What we were actually producing, the output was vaccinated children. That was our output. Our outcome was the avoidance of a pediatric intensive care unit stay for children with the flu. That was our long-term outcome, and it was produced by vaccinating more children. So the process was really for the flu vaccine project, the process was building the registry, building best practice alerts, working with the clinics to help them find the time and the resources to increase their vaccination rates, working with the pharmacy to help them figure out supply issues. That was all process. And their output was number of kids vaccinated. And then once we had kids vaccinated, our long-term outcome was kids not ending up in the hospital. So those might not be the same kids, and the kids who show up in the outcome might not have been part of the process of the output, but that was still our desire. Our overall goal was to reduce the number of admissions for flu. I like this chart. This chart puts together the input, which is the activities or intervention, the process, and the output measures. And what I like about it is it kind of puts it in a little bit of a chain. You got to do one to do the other, but it also points out how if we're looking at whether or not we're being effective, it just reminds us that we're always going to be looking at those outcomes. Effectiveness really isn't measured in any other way than looking at outcomes. And then when we want to look at efficiency, we don't really look at outcomes. What we look is output. What did it take to get one child vaccinated? That's an efficiency measure. In the case of the flu vaccine, the resources we had were nursing staff time, information management, data analytics and reporting, and the flu vaccine. We had actually a lot of other team members across the organization participating. How do we do that? We use it by best practice alerts in EPIC, the high-risk registry, training for nurses and parents and clinicians. What did we produce? More vaccinated patients. And what did we get? Flu or flu-based PICU admissions. So that was our design. That was our intervention theory. And it pretty much went the way we expected it to, with some hiccups, which I explained earlier. So the nature of good analytic questions is very, very much tied to the notion of having a coherent intervention theory. But we need to kind of step back and think a little bit, not just about the intervention theory, about just what is the nature of a good question to begin with. And researchers use some language that's very, very helpful for us in the program, in the quality improvement program evaluation and translational research world. They ask, in order for a question to be a good question, it is always something they call falsifiable. And that is, using data, you can show that your assumption is incorrect. It's much harder to show that something is correct. It's much easier to show something is incorrect, so researchers tend to focus on showing that a hypothesis is rejected. That's kind of a technical subtlety that many people get hung up on, but it's actually logically correct. And so they use this notion of being falsifiable. And that's a really important distinction when we're using data from the EHR, because data from the EHR is very hard sometimes to validate. Sometimes its reliability is very much in question. And if you don't have valid and reliable data, you're not going to be able to falsify a question. So even though that seems very theoretical, it's actually something we run into with some frequency. The causal order is correct. This is a really basic thing, but when you're working in a real world setting where there's all these weird behavior feedback loops, it's hard to sort out that your actions are actually triggering the things that you want to measure as an outcome. And so in a real world setting, this can get pretty difficult to tease out, but so it's important to measure it. It's another reason to have a good intervention theory, because an intervention theory will probably pick up on some of those feedback loops, and you'll understand whether or not you're actually triggering the outcome you want to have. The concepts within the questions can be operationalized. This is a term that, again, is used by researchers. It's a really important term. When people call our department, Data Analytics and Reporting, and ask for any data, we sit down and we ask them about probably 20 or 30 questions, and they usually want to pull their hair out. But the questions we're asking them really deal with how they're operationalizing their question. So if you come in and say, I want to know about readmissions, please give me data about readmissions, we'll say, readmissions over what time frame? 7 days, 30 days, a year. Readmissions for the same condition, for a different condition, for all conditions. And there's an unlimited amount of questions that we can ask, but our desire here is to get the requester to get a much more precise question, and a question that eventually can actually be measured with data. So taking these ideas about what makes a good question and thinking of those ideas of falsifiability, and causal order in the context of interventions, there's something we like to do as well in the analytics world, and that is we like to do what I'm going to call an analyzability assessment. Now, I know that's kind of a mouthful, but what I want to put forward here is a series of questions and things to think about before you even say this is a question that can be analyzed, or this is an intervention that can be analyzed, because they can't all be, because sometimes the data aren't sufficient, sometimes the intervention theory is not very well worked out. We need to kind of assess whether it's possible to actually do it. Or I would say sometimes it's possible, but the intervention's just not ready for it yet. So the first thing an analyst would say is, does the intervention theory make sense? Does it make sense on the face of it? We've already talked about that, that's something that the planning team should be thinking about all the time. Does this make sense? Is this coherent? Could this really happen this way? Is the intervention theory, or is the intervention itself fully operational? Or can it be in the time you want to observe its effects? Lots of times we will stage in interventions over a period of time. We'll kind of put our toe in, pilot a little, expand it a little bit more, change it a bit, go a little bit larger. And each of these stages is an important learning stage for the planning committee, but it also can mean that there's not enough data to really observe the impact of the intervention. And so thinking really hard about at what stage in the operation of the intervention will we have enough data that we'll know whether it's effective or not. If we measure anything before then, it's really just not going to be a good use of resources. Another aspect, another thing we think about when we do an assessment is, can you get the data? As I've mentioned a couple of times before, if the data are in the electronic medical record, they may or may not be able to be pulled. If we pull them, they may or may not be reliable, which means that they may not be entered the same way between clinics and between clinicians. And so it means one thing for one clinic and another thing for another clinic. And then we need to know that they're valid, that they mean what we really think they mean. This can be a really tedious and long process once we know we can pull the data. Figuring out whether the data are entered in a reliable way and whether they're really valid can be a little bit of a time, can take some time. And in fact, it often leads to a process improvement project that is a kind of a sub-project of the big intervention in order to improve the data collection so that we can get good outcomes data. Can you get a baseline or a strong control? Now, people who work in the quality improvement space might not want to have a control. They might not think that that's appropriate for what they're doing, but most of the time they do want a strong baseline. And so in the next session, I'll be talking about quasi-experimental design. So I'm not going to touch on that right now, but we do really need to have all of our evaluative thinking around whether something's effective. It's all based on this notion of comparison. So we need to figure out how we're going to make a comparison. Otherwise, we just have kind of outcome numbers kind of floating in space. We need to kind of anchor it to a baseline or to another group that's not getting the intervention. We need to have some way of saying, this makes a difference, this was good, this was effective. Can the things the stakeholders want to know be measured? There are some times that we're asked to do an intervention where the things that we want to measure most sometimes cannot actually be measured very well at all, or that they would be measured, but it would be such a time-consuming thing to do that it's not worth it. So really thinking hard about kind of what the stakeholders need to know to move to their next stage of action and how to figure out how analysis can support that is really key to developing a successful analysis plan. And this goes back to number two, is there enough volume in the program to use quantitative methods? There are some times the programs are so small, even though they're organization-wide, that even when they're fully operational and every patient or staff person who's affected is experiencing the intervention, it's still that the volume is too small for quantitative methods to be used. And then finally, is the intervention worth investing analytics resources in, and how many resources? And this, of course, is a big question that we involve leadership in when we decide this. But generally speaking, the way we approach this in this hospital, that there's a few areas that have really been prioritized for resource support, and those are the ones that are going to be the first ones up to get resource support around analytics. I would add here, it's really worth investing in it if the outcomes are going to be especially useful to the organization, if we're building towards something big. Of course, that should be sorted out in the prioritization process. So I want to go back to how we come up with good analytic questions. We've talked about some basic things that make good analytic questions, that they're falsifiable, that you have the causal order right, that they are things that can actually be measured and operationalized and counted in the way we analytics counts events. So let's just talk for a few minutes about how you get to those good questions. You have gone through the process of doing an analyzability assessment. You think that your intervention is going to stand up to it. So this is the way I generally approach creating and developing analytic questions. So first, I want to see the intervention theory, and I want to see that it's going to be something that's logical and makes sense, and that can be operationalized. Then I think once you've got that laid out there, as I mentioned earlier, one of the things that happens when you have an intervention theory and you have this big meeting of the minds where everybody surfaces all their assumptions and puts all these additional boxes on the intervention theory, and it can look very, very confusing. The next step for the person conducting the analysis is really to sit down and get to the heart of what the stakeholders need to know in order to move forward. What is the outcome that they're searching for? That should be pretty obvious. And then where are the points in the process where they need additional data collection? So usually what we'll do is we will always measure the outcome, presuming there is an outcome that's measurable. But we'll also want to figure out a couple of process points in the intervention where it makes most sense to do some data collection and evaluation. And the reason we want to do it at a few key, first, we can't do everything. So we want to pick 2 or 3 places where we think maybe the system is more likely to break down. There's a new intervention that's going to require a little bit more support. There's some assumptions people are making that may or may not be valid, and there's lots of disagreement about it. Those are areas where you're going to want to put a little bit more analytic resources into it. And then that way, if you're not getting the outcomes you want, you can go back and look at those other pieces of data and say, maybe one of these will explain why we're not getting the outcomes, and we can tweak our intervention theory a bit. Then once you've kind of gained agreement and kind of figured all that out, then it's time to really do some tough work of operationalizing all the concepts in the analytic questions and developing the path to collect the data and analyze it. And I would say that this is the end result here is we end up with an analytic plan that is a subset of the intervention plan, but it really stands on its own in relationship to that plan. And the analytics plan really kind of only makes sense because the intervention theory and the intervention effort is so well laid out. And then once you've put the analytic plan in place, meet with the stakeholders, go through it, make sure that it's kind of what they had in mind. Hopefully at that point you're just tweaking it. So the last thing I want to talk about is what makes a good analytics effort. I think by now it would be pretty redundant for me to talk about intervention theory again, but of course I have to mention it because the analytics is just the caboose. The intervention theory is the thing that drives the train. And so if we don't have a good intervention theory, we cannot have a coherent analytics plan. And so I hope that's been clear from this talk today. And then if we have a coherent intervention theory, we're going to have good analytics questions, and we're going to have good consensus among the stakeholders about what's important and how to put our resources together. And then the other thing we need to really think about, so far I've talked a little bit about how the analytics plan helps the stakeholders understand whether the intervention theory is working well. Another aspect of the intervention needs of the stakeholders is thinking about what their next projects might be and what they might have down the road, thinking about how this information and analytic plan might feed that better learning for them. it's a useful question to ask as you're finalizing the analytics plan. And then I think finally, the right analyst for the job. There's a really wide range of analytic types, and doing a good match between the skills of the analyst and the requirements of the project is key to being for the project being successful. So I want to thank you for listening, and I hope this was helpful to you, and we'll be posting it online, and the third session will be coming up shortly.